Hmm. Good afternoon. Um, my name is Professor Jonathan Weaver. I'm the co-director with Professor Sophie Day of the Pears Cumbria School of Medicine Research Hub, and I welcome you to the latest of our CumbriaMed Research Webinars. These webinars bring together the science and clinical medicine from our partners, Imperial College London, the University of Cumbria, and North Cumbria Integrated Care Trust. And through the webinars, we hope to bring cutting edge science in areas of medicine important to all of us, together with representatives from our partners in Cumbria, with what's going on the ground in these important areas. So in this webinar, we will focus on respiratory diseases, and in particular around viral vaccines and how they can influence respiratory diseases in adults, and then on the enhancement of chronic respiratory disease, chronic obstructive pulmonary disease, COPD. So without further ado, I'm delighted to introduce Professor Peter Openshaw. Peter is Professor of Experimental Medicine at Imperial College London and will be familiar to many of you as a voice of reason and science during the COVID epidemic and subsequently. Peter's the past president of the British Society of Immunology and an expert on viral infections of adults and of their prevention. Peter, over to you.
Well, thank you so much, John. It's very kind of you to invite me along, and I'm looking forward to the discussion, which I hope it will be after our talks. And I've tried to keep this short, but there's so much to say about vaccines. Yeah, I just hope I can fit it all in. I think to just start by saying it's amazing how much survival to adulthood has changed in the past 150 years. Throughout history, going back 2.5 millennia, it's actually been unusual to survive through to reproductive age. The death rate, particularly amongst children, has been extraordinarily high throughout human history. And it's only with the advent of modern medicine and vaccines that we've seen that change. And about 40% of the improvement in survival through to adulthood is ascribable to vaccines. So a remarkable success story. So this is a sort of a graphic I rather like because of its colors and the sort of the serpent you can see going through time, looking at the major landmarks in terms of vaccine development going right back to the time of Jenner and the introduction of the smallpox vaccine. And I've just put red circles around the vaccines, which are really respiratory vaccines. And you might think, well, nothing much has happened in recent time. I don't know if you can see my pointer. I'm going to just put a laser pointer on there, but you can see, even in this period, there was still vaccine advances. But since this graphic was made, we've now got RSV vaccines, respiratory syncytial virus vaccines, which I'll speak a bit about. Changes in the flu vaccine approaches, and of course the COVID vaccines, which so many of you will be very, very familiar with, which I think has been a remarkable scientific achievement that those were introduced so quickly and they were so effective at preventing severe disease. So just to set the scene, I thought I'd show these two nice graphics from the UK Health Security Agency, which are basically just outlining who is eligible for the influenza vaccine and who is eligible for the COVID-19 vaccine. I just thought I'd get these out of the way because they are the two sort of bedrocks that you would think about when you're thinking about vaccines that protect adults from respiratory disease. So not everyone gets the flu vaccine, but it's pretty wide. It's not hard to get the flu vaccine. They've been around for 30, 40 years in various forms. They're remarkably inexpensive. And that's part of the reason that we have such a wide rollout. At the moment, we're delaying until October in terms of getting vaccines into people, because we're hoping that the major peak of effect of these vaccines will coincide with what's anticipated to be the flu season. Now, many of you will have had many COVID-19 vaccines, and these are being continued. They're much more expensive. They're rather more restricted in their distribution. And if you do have an underlying susceptibility, you're quite likely to be eligible for a vaccine. And I would just encourage everyone to have these two sort of bedrock vaccines if they are eligible, if they're offered. These are very carefully tested, evaluated, and they wouldn't be recommended by UKHSA unless they were really worthwhile. I will certainly be looking for my, I think, 6th COVID vaccine this autumn. So I hope you'll allow me to just speak a bit about my favorite virus. I actually did my PhD on this virus starting in 1985. So I've been working on this virus for a very long time. And I think the first thing to say about it is what a terrible name, respiratory syncytial virus. Even I find it hard to say at times. And if a taxi driver asks me, what do I work on? I say respiratory syncytial virus. He says, never heard of it. Don't know what that is. So it was a great shame, I think, that this rather long-winded and difficult to say name was chosen. And I think partly is because of this appalling name that it's so little known about. When I started working on it, we really thought about it as a virus that causes wheezy colds in babies. And many of you who've had children will be familiar with the wheezy colds that babies get, and some of which end up in hospital. It's a major single cause of infant hospitalization for respiratory disease, in fact. But it was only in maybe the last 20 years that we've started to appreciate that it's also a very important virus in the older adults, particularly the frail elderly, as you might say, where it presents as a very different sort of disease, rather gradual onset. Typical story might be that the grandchildren come home at Christmas, smear their respiratory secretions all over the grandparents, and about a week or two later, the cold has gone down to the chest and their pre-existing COPD, chronic obstructive lung disease or whatever, has deteriorated, and then maybe the week after they're admitted to hospital. And it may take maybe 4 to 6 weeks for them to die following the Christmas visit from the grandchildren. So the children are the vector. The older adults are the major casualties in terms of those who actually die of RSV disease. But it was a largely hidden affair. So a big change in our understanding of the impact of RSV, a rather sneaky virus that often seems to go underneath the radar. But it's every bit as important as influenza in terms of older adult mortality. And these are survival curves in people who have been admitted to hospital with influenza or with RSV disease. And you can see that if you go to 1 year follow-up, then about 20% of those admitted with influenza will have died, whereas it's about a quarter of those who've been admitted with RSV. So the 1 year mortality following admission with these viruses is somewhat similar, but greater with RSV. So it's a very important killer of older adults as well as children, particularly in developing countries, but I won't go into that in too much detail. So this is a slide just illustrating, the way in which it's a hidden disease, both in the pediatric population, where there's a big economic burden, which is often hard to estimate, from parents having to take time off work or time, when they have to be in hospital with their children who've been admitted. But in the elderly population, there's a huge hidden burden because it's so infrequently diagnosed. It's quite hard to find the virus in older adults because it's only present often in lower respiratory tract secretions. It's not often present in the nose. and it's often present at maybe 1/100th the viral load that you would see in children. And most of the diagnostics are optimized for childhood disease. So it really is a hidden killer of older adults. So all the time I've been working in the field of RSV, we've been looking for ways to vaccinate. And all of the attempts were made using the fusion protein on the surface of the virus in the extended so-called post-fusion form, where it's flipped out into an extended sort of arrow. But the pre-fusion form is what we should have been working on. And it's years of meticulous basic science that finally showed that the protein on the surface has these two different forms. It can flip between them. And we've been using basically the wrong one. And it was only when we could use the right one that finally rapid advances in vaccinology were possible. So just to emphasize, all this wonderful basic science that goes into underpin the development of vaccines. And this is what the sort of vaccine pathways, the landscape for vaccinology for RSV looked like as of a year ago. And we've got live attenuated vaccines, protein-based vaccines, nucleic acid-based mRNA vaccines, and also immunoprophylaxis with antibodies, which you could say is a sort of vaccine, which provides direct protection for infants. So, quite a rich landscape compared to what we had a few years ago, where basically nothing was working and we were almost despairing of ever having vaccines for RSV. So I won't show you a lot of details, but this is one of the trials that was done on the Pfizer vaccine, where they randomized a very large number of people, 60 years or older, to the Pfizer vaccine or control, and then followed up for 2 years. And you can see that the controls accumulated a lot of RSV cases, whereas these are all hospitalizations in older adults, whereas those who'd been vaccinated, it was virtually 100% protection for about 10 months, and then a few breakthroughs, but quite extraordinarily effective. I couldn't stop smiling for several days after I first saw this, because we never thought this was going to happen. It was so exciting. So Pfizer and GSK, fairly similar sort of effects of their vaccines, but the NHS has done a good deal with Pfizer, which means that we're using the Pfizer vaccine. So if we look at what's been rolled out in the UK, it was focused, perhaps a bit surprisingly, just on adults 75 to 79. So when you've got to 80th birthday, you were no longer eligible. And a few eyebrows were raised over this, but I think what we were doing was just introducing the vaccine slowly, because some of the trials had been a bit small. They were done during the time of COVID, and we just wanted to see what sort of effect this would have in real terms. So very narrow. And I don't know if anyone online has had this vaccine, but you're one of the privileged few if you have. And it's quite an expensive vaccine. If you try and get it in the States, it's several $100s. Now, this was one of the first bits of UK evidence that it really was working. So if we look at the age group in which you were eligible for this vaccine, just these 5 years, and you can see that the hospitalization rate against the age, there's a sort of dip in the data here, which was present even though we'd only vaccinated about 40% of the eligible population. So once that was corrected for, then the vaccine effectiveness was 72%, which is sort of what we'd expected, which was quite remarkable. It's almost as if this rather limited introduction was designed in order to get this sort of real world data to show just how effective the vaccine is. So we also introduced the same vaccine. So it's much easier for the NHS to have the same vaccine for different uses. given to pregnant women from week 28. There was various concerns and hesitations about this, but by boosting the antibody levels in the mother, it was hoped that babies would be better protected against RSV disease. And I'm very pleased to say that my own daughter was amongst the first women to be vaccinated in the UK. And I hope you won't mind a proud grandfather just showing a picture of his latest grandchild. Here she is. So this is Clara, who was protected by her mum being vaccinated against RSV disease. And I'm sure the reason for her being so poorly when this photograph was taken was nothing to do with RSV. So that isn't the only way you can protect children. You can also give them this shot, which is delivered very soon after birth and which protects them for quite a long period, probably as long as maternal vaccination. So if you have a premature baby, you can protect them very effectively just by giving them this single shot of antibody, which has been bioengineered to be long lasting, and which is used very widely in many countries now, and which has had a massive effect on hospitalization. You know, the pediatricians are wandering the wards, putting their feet up in the coffee room, wondering where all those children are that they used to have to look after. So I just want to go on and talk about another way that adults can be protected, and that is by vaccinating children using a nasal spray with this live attenuated influenza vaccine, or LAIV. So this is one of the forms of vaccine that was developed in the last couple of decades. And it's been given initially back in 2013-14 to young children. And then as the years go by, it's been extended to older children and used via school services as well, delivered in schools. It's much better uptake. And actually, the uptake has been remarkably good. You know, kids and parents and teachers don't mind giving kids a nasal spray. And this has now been rolled out very widely after trials in various locations around the country to see just how this nasal spray vaccination could be distributed. It's, again, amazingly protective. So 94% reduction in GP influenza-like consultations. Just that's an amazing achievement in terms of preservation of health and prevention of disease. So A&E attendances are down and hospitalizations are down, but I put a red box around this part of the graphic, which shows that also adults are being protected by children being vaccinated with this nasal vaccine that not only protects the children from the severe disease, but also stops them passing it around to their older adult friends, cohabitees, relatives. So nearly 60% reduction in influenza-like consultations in older adults. That's amazing, really. And this is showing the same sort of effect. So in the pilot areas where they were rolling out these vaccines, there was a much lower workload in terms of influenza-like illness as a result of households being protected with this nasal spray vaccine. So in terms of GP consultations, you know, it's lightened the workload for GPs remarkably. So GPs are delighted. I'm very happy that this program has gone ahead. And this is some NHS posters, you know, showing the many reasons why people should be keen to take these vaccines, not only to protect the children, but also to give community protection, including protection to vulnerable adults. So just to sum up and conclude, so we've got these regular flu vaccine shots and COVID vaccine shots, which if you're eligible, I would absolutely recommend you take, and which I will be taking. live attenuated flu vaccines for children have this indirect protective effect. There's these amazing new RSV vaccines, which make me so happy that they have been successful and based on a massive amount of science, much of it done in our universities, and maternal vaccination, which we haven't talked about too much, but which again is so important in terms of protecting both the mum and the child. So thank you all very much.
Peter, thank you so much for a terrific presentation. If I can ask you to unshare. Perfect, thank you. Delighted to introduce Dr. Tim Gatherell, consultant physician at University Hospitals Morecambe Bay and senior academic at the new Piers Cumbria School of Medicine. Tim, over to you.
Thank you so much, Jonathan. Let me just get my slides up. It's a pleasure to be invited to speak today in such august company. Very much enjoyed the first talk. But I'm going to speak to you, if I can get my slideshow to work. Here we go. Okay, there we are. Hopefully that's showing. So I'm going to talk to you about our local respiratory network, which we're very proud of, the Morecambe Bay Respiratory Network, and really focusing on how that enhances COPD care and chronic respiratory disease more generally. And I think quite an exciting model potentially for future delivery of healthcare, which is increasingly challenged, as I'm sure many of you will agree. I'm a consultant physician in University Hospitals of Morecambe Bay, also a senior clinical lecturer at Lancaster, and more recently appointed to lead the respiratory course at Piers Cumbria. So in terms of my background, before coming up north, I trained in Cambridge and then in London for my postgraduate training. And to sort of link the Imperial side of things, I undertook my PhD at the National Heart and Lung Institute. Professor Jay Mitchell was my supervisor, and that was a lab-based project on innate immune signaling in models of lung inflammation. We can see at the top a poor Drosophila fly there that is suffering from overwhelming fungal infection because it's deficient in a protein called toll-like receptor 4. Which now discovery of this protein, which recognizes lipopolysaccharide, an essential component of many pathogens. The recognition of this led to a Nobel Prize in medicine. Unfortunately, my PhD didn't lead to a Nobel Prize, but it was based on innate immunity and how we recognize pathogens immediately as they enter the body and the relevance of that to lung inflammation. So that was some of my research background. After finishing my PhD, I undertook an NIHR lectureship based at St George's Hospital, in the picture there, also where both of my daughters were born before we moved up north, and working with Professor Emma Baker. That was sort of my first foray into looking a little bit more at COPD, and particularly the impact of bronchiectasis, which is another chronic respiratory pathology where there are enlargement of the airways, where phlegm gets stuck chronically within the lung, and it can lead to recurrent inflammation and infection. And we're increasingly aware that bronchiectasis can be a feature within COPD. Now, without going into detail on that study, I think what that shows is that COPD itself is a very rich and varied disease. Sometimes within medical training, we like to get things down to basics and pigeonhole diseases based on a few criteria. But the more you look into things as a specialist, the more you realize the very rich depth and variability that common diseases like COPD can actually present with. And actually getting to grips with that depth is really important in how we manage disease going forward. So it was time to move. I'd finished my registrar training and lived very near South Wimbledon Station on the left. And you probably will not doubt why the decision was to move up north. So this is the view I'm very lucky to have from my back window now, living in the Yorkshire Dales. But there was also, apart from wonderful scenery, people and quality of life, lots of opportunity coming up north, the ability to shape my own practice in an area and get to grips with the academic opportunities offered in Lancaster and elsewhere. So that was in 2014. Now, as I say, plenty of opportunity, but plenty of challenges. And I think it's fair to say that in the Northwest generally, there's a very high burden of respiratory disease. There are lots of areas of deprivation. In Morecambe Bay particularly, the geography is quite important. University Hospitals of Morecambe Bay has 3 hospital sites: Lancaster, Barrow-in-Furness and Kendal. It's over 50 miles to drive between the 2 acute sites, and we've got a lot of different areas of natural beauty, but also more deprived urban areas. So it's quite a mix, and actually that distance between trusts has economic issues associated with it and how we run our hospital services. And I think it's fair to say when I arrived, there was perhaps not ideal coordination between primary, community and secondary care. And this is by no means limited to Morecambe Bay. This is something I think we can see quite often across the country. Because of our quite rural nature, in terms of recruitment and coordination between care, that's been a real issue. For example, those with more severe respiratory disease, severe asthma, for example, or my subspecialty, which is interstitial lung disease, if you required referral to potentially get disease-modifying therapies or newer therapies, that could entail a very long journey to Manchester, Liverpool, or perhaps Newcastle. If you're a patient in the Barrow area, that's a 4-hour return journey to Wythenshawe Hospital in Manchester for interstitial lung disease. So these were big challenges in how we could deliver excellent care. And just to sort of show, not only do we have higher rates of chronic respiratory disease in the Northwest, but when we undertook an audit of our asthma and COPD populations using several criteria of severity, we could actually see that vast numbers of the patients on our Morecambe Bay register with these diseases actually hit these high severity criteria. That may be numbers of exacerbations of the disease in a year, numbers of patients on the highest tier of treatments in terms of inhaled treatment, or the requirement for oral steroids or other advanced therapies. So we have a highly prevalent chronic respiratory disease is highly prevalent in our area, and it's severe. So what to do when you're a new consultant, you have the opportunity to meet great colleagues and collaborate and try and find out novel solutions to managing the health needs of your population. My colleague Pat Haslam at the time was a GP trainee on the respiratory ward, but took a great interest in how we could unite primary care and secondary care together. We both attended the ERS conference in London back in 2016. And it was one of those moments where your colleague said, let's have a coffee. I've got an idea. And things grew from there, really. So beware of those situations. So the Morecambe Bay Respiratory Network was born. This is how it started, very small scale. And I'll go on to say really what the Morecambe Bay Network means very briefly. But this was one of our first MDT meetings, uniting community nurses, myself staring in great detail at the X-ray on the screen, and GP colleagues as well, along with physiotherapy colleagues. What is the MBRN, the Morecambe Bay Respiratory Network? In a nutshell, it's a collective of healthcare professionals engaged in respiratory practice across Morecambe Bay. Our model shifted funding from secondary care to primary care. So extra funding to primary care and community teams to improve delivery of respiratory care. Each practice could do that in their own way, perhaps designated time to assess patients, discharge follow-up clinics if the patient's been hospitalized. It was really quite flexible, but the idea there was extra funding for practices to deliver more precise or give more time to respiratory care. To facilitate that, we allowed direct access to specialist investigations, for example, CT scanning, pulmonary function testing. And we gave guidance across the network for common respiratory disease management, so COPD management, asthma, bronchiectasis, and interstitial lung disease. Crucially, we back up the colleagues in the community with a monthly community MBRN MDT, with 1 or 2 consultants participating, as well as community respiratory nurse specialists, GPs, physiotherapists, etc. And that's where we can discuss the more complex cases and provide that educational feedback. And as well as that, a comprehensive and regular and very well attended education program. Just to show you the geography. So MBRN covers both the Lancaster site, South Lakes and Barrow. Initially started in the Lancaster area, moving over to Barrow a few years later, and very recently funding was approved for the South Lakes. But this gives you an idea of the geography of our patch and the distances involved in coordinating care. As well as this being a clinical project, there was the opportunity to look at this academically with partners at both the University of Cumbria and Lancaster. So here are some of the papers that I'll go on to talk a little bit about. Initially, we utilized the extensive medical data science unit at University of Lancaster to start to model in more detail how patients were presenting with COPD and emergency admissions. So that was a PhD project that I co-supervised. Then a key paper looking at MBRN was a PhD student, Rachel Mountain. Again, I co-supervised that project, and this was looking at novel ways of modeling referrals into secondary care and really trying to in-depth understand the impact of our model on healthcare demand and outpatient demand. And then we've gone on to also have a look at how we can use routine data to better understand chronic respiratory disease. So just some highlights from that. This is Rachel's paper. Now, I just wanted to sort of highlight the graphic because it almost looks as if it's a slight sort of dose response curve for a drug investigation. This isn't a drug. This is the effect of our network on referrals into secondary care. Now, we've split the different lines in red. That's practices that had no involvement in our network. Green, where there's 100% involvement. And in the middle, this will be a patient that maybe straddled an area where the network was involved or not. And you can see very clearly from the onset of MBRN back in 2016, 2017, a divergence between those practices in the network and not, and a dramatic reduction in referrals to secondary care. That may or may not be a good thing. We are here in secondary care for a reason. But our argument was by doing respiratory medicine to a higher level of detail, in a supported fashion in primary care, that many of the reasons that patients are being referred into hospital could be avoided. And that's important because hospital systems are absolutely overwhelmed in terms of specialist referrals. You can see in the right-hand curve that referrals post-pandemic have gone up steadily for other medical specialties, but continue to drop for respiratory. So we think we may provide more efficient care, but do we provide better care? And defining better care can be difficult. These are some statistics that we've chosen to show the effect. Now, pulmonary rehabilitation is a very important evidence-based intervention in COPD. It can improve quality of life, exercise capacity, and reduce hospital admission. And you can see a dramatic increase in the numbers of patients referred for pulmonary rehab since the network has come into play. Obviously, data for this year is not fully there. We've also shown that in the MBRN cohorts, we are reducing the respiratory medication spend per patient by rationalizing medication, ensuring correct medication, and stopping inappropriate medication. And although it's complicated post-pandemic, we're beginning to see a signal in terms of reduction of admissions for patients with chronic respiratory disease being admitted to hospital in the MBRN cohort. And finally, reduced use of short-acting bronchodilators in the MBRN cohort of patients, implying better practice. What does this mean for COPD care? We think early, accurate diagnosis is a cornerstone of good COPD management, and our integrated, supported environment in the MBRN enables this. Early discussion of complex disease in the community MDTs is crucial, and crucially, access to the multidisciplinary team. So much of good COPD care is not about the doctor, it's about the wider healthcare team. Joined up management of severe disease, including more advanced palliative support for advanced disease, and fast track referral if more tertiary interventions might be required, such as lung volume reduction, endobronchial valves. We think this could be a template for potential future treatments of COPD, including biologic therapy. Sometimes it's better just to put it in a patient perspective. This is an example of a patient who's having multiple courses of steroids, multiple consultations with their GP, including respiratory outpatient involvement, using the MBRN approach and the multidisciplinary approach, a dramatic reduction in need for rescue treatment and admissions. It's not just about COPD. We also look at ILD and bronchiectasis, which have been regarded more as specialist diseases, not necessarily as much management in primary care. But in MBRM, we actually have annual reviews in GP practices for these conditions and fast-track referrals to my interstitial lung disease clinic and severe asthma clinics as well. This was some data we presented showing the effect of the MBRN in referrals for fibrotic interstitial lung disease. You can see at the top left, we've got the time from CT to referral into the ILD clinic. In the MBRN cohort, they've all had their CT scans over a month before they're even referred, because we've allowed direct access to tests. And that led to a dramatic reduction and clinically relevant reduction in this very dangerous disease of access to specialist antifibrotic therapy. Coming to the end, just a little illustration of some of our MDT data. You can see that COPD and asthma remain the most commonly discussed conditions in our MDT, but significant amount of discussion of ILD and bronchiectasis. And crucially, disease often stays under the radar, such as inducible laryngeal obstruction, which is often a feature in uncontrolled asthma. Only out of all the patients discussed, over 300 patients in this audit of a year, 30% required referral, so 70% were managed without referral. And of those referrals, 85% were directly to a tertiary care service, so avoiding a lot of the steps that patients have to wait in and waiting lists when they need specific respiratory care. I think you'd agree that the health service has lots of challenges. Access to clinics is very difficult. This is part of the 10-year health plan, Lord Darzai's approach. West Streeting's recent announcements on the 10-year health plan. And I would argue that the MBRN approach of utilizing the massive expertise we have in the community with our GPs, combining that with specialist approach to provide better care is the way forward. But it's challenging. And I think the last slide really on the MBRN is this is one of our education days. So well attended, the enthusiasm in the room. It's tough being in healthcare at the moment. It's tough being a patient. And I think the joy in the room that you get from these events and everyone working together is a really important and precious thing. And that is the end of my talk. Just say you've got to be careful when you start to collaborate with colleagues. This Martin, one of the GPs in the founding of the network, we mentioned that we both ran a bit, and the next thing we're running up mountains in Switzerland. So you've got to be careful what you get into. Thank you.
Tim, thank you so much for that presentation. Very uplifting presentation, drawing attention to the particular challenges of Cumbria in terms of geography, accessing tertiary, secondary care with the distances people have to travel. But two great talks on respiratory medicine. So I'm afraid to say time is out. Can I thank both the speakers, Peter Openshaw and Tim Gatherall, most sincerely for terrific presentations and great answers to the Q&A. Can I thank everyone who's attended today? It's been very well attended and it's been a terrific webinar. Thank you very much.